Thanks, everyone. Today I'm just going to be talking about some modelling work that I was involved in. It's a little bit old now, actually, but I think it still has some relevant points around the modelling, testing and treatment strategies for infectious syphilis outbreak among the Aboriginal and Torres Strait Islander people. And I only have a short amount of time, I believe, so I'm going to be doing quite a quick summary. But to begin, I'd obviously like to acknowledge the lands of the people I'm presenting from, which is the Dharawal people in southern Sydney, and also acknowledge where Kirby Institute is standing on the lands of the Bedjigal people, and pay my respects to elders past and present, and acknowledge any Aboriginal and Torres Strait Islander people in the attending today and listening to me. To begin, I guess just giving you a brief overview of this modelling work and hopefully focus on some conclusions towards the end. This work was done for the MJSO working group sort of in 2018, 2019, 2020. Its really aim was to provide guidance, and I guess this is quite general guidance for rolling out an enhanced test and treat response and for developing activity plans. And so forth, similar to what's happening today, I believe. And I guess sort of, question is, that was the focus. The question that was under focus was around, what do we need to do to return syphilis prevalence in Aboriginal people to pre-outbreak levels within a 5-year period. I just want to note that the results were provided to MJSO and they've been published in a report that's available on this link, and we've also published it in a paper which is available here. And I guess I'll be just presenting the results from this paper, which I guess is sort of was where the work finished up. And I just would note that everything we did was pretty much done before COVID appeared and through any spanners in the work, so to speak. And so I guess I'm sort of talking up to around the end of 2020. Okay, so I'm not going to go into the technical details of the model. I just want to just briefly touch on the key aspects. And I guess the first thing is that the model is looking at infectious syphilis transmission among heterosexual Aboriginal people who are aged 15 to 34, and we have them living in regional or remote areas. So this model doesn't consider urban areas. I guess it was really focused on the regions that were affected by the outbreak initially. I do know things have progressed since then. And I guess the purpose of the model is to assess the impact of the control responses on the existing outbreak that exist, I guess I should say, in the hypothetical scenarios. It's really designed to capture overall national characteristics of the outbreak rather than specific jurisdictions. And I know I've been asked about this a couple of times from people in WA, but we didn't have the capacity or were unable to really run specific areas, unfortunately. So it does mean we've got quite a generic, general model, which is focused on the national picture, but I think the lessons are still relevant for every area or region. I guess the model is fairly simple. So we've got sort of a regional centre with 10 more remote communities which have smaller populations, and the model's set up for individuals to move between the regional centre and the remote communities over time, and I guess potentially spread syphilis around between those centres and different communities. We tried to incorporate all the available data that we had, including population movement and sexual behaviour, and included details around syphilis, disease progression, testing and treatment. Because the modelling was about really focused on testing and treatment, some points about that. And the first thing is really the key variable here is the proportion of individuals who were tested in the previous 12 months, or the coverage of testing. And that was we wanted to look at scenarios where what would happen if we increased the coverage. What if we could test more people and more quickly? What if we could test a lot of people at the same time? I just have some notes here about how we calculated coverage. It was really just coming from the MJSO working group data that they provided us. We did have to make some adjustments and estimates due to some difficulty. The data wasn't quite as detailed as we sort of needed it. But we did try to come up with some estimates for annual testing coverage prior to 2013 and then sort of from the 2013 to 2020 period, with some variations between sex, region, and age group, but we did have to rely on other STIs to inform that. I guess in terms of treatment, the model essentially assumes sort of everyone who's diagnosed is treated effectively, within sort of 7 days within a regional area, but could be much longer for remote areas. Okay, so using this model, what did we do? Well, we ran some scenarios where we looked at, so what happens if we increased testing coverage going forwards from 2020 to 2030? I guess we tried to make these feasible, and so this was informed by, I guess, the MJSO working group and consultation with others. And then we also looked at this idea of implementing community-wide testing, which is sort of a situation where we can test a lot of people quickly. So for the purpose of the modelling here, this was 30% of people are tested within a 6-week period. And that happens sort of everywhere. And so all of the communities, this was only a community-focused, remote community-focused intervention, because it wasn't thought to be feasible in sort of like a regional or bigger setting. And basically the scenarios here are really just sort of touching, so what happens if testing didn't increase since 2013? What was the effect of testing increasing up to 2020? And then what could happen if we increased to much higher levels within a 2-year, 5-year period? And what happens if we had community-wide testing occurring in conjunction with that increase in testing? Okay, so firstly, in terms of results, I guess on the left here, I've got sort of notifications. These are national notifications from MJSO affected areas in red, and the grey and black lines are sort of showing you what the model produced. And I guess this is sort of like 100 scenarios where we got quite good match between the notifications data and the model up to 2020. And then these were used to project forwards into the future. I would note we are assuming an outbreak occurs, so we're not really exploring why it occurred, and we're not looking at a situation where why had previous syphilis sort of flare-ups died away instead of becoming an outbreak. So this is more about, we know a syphilis outbreak occurred, and we're getting the model to match that happening. On the right, I guess, is a simple sort of graph showing you diagnoses in the model if there's no change in testing versus with the increase in testing up to 2020. And I guess the take-home message here is that with the increase in testing, we did see an increase, but then a plateau. This plateau perhaps happened a bit earlier than what Donna mentioned in the WA epidemiology. It's sort of happening before 2020, but it is a plateau, but no real decline evident. Without the increase in testing, we'd just see a continued growth of notifications or diagnoses occurring. So I guess you could say the sort of response up to 2020 did have a plateauing effect on syphilis. In terms of testing strategies, this is a sort of figure here, which is quite busy. Sorry, I'm not sure how big a screen I'm presenting to here, but I guess in principle, there was sort of the 5 scenarios I showed you in the table before, but on the side here on the right is sort of telling you roughly what those scenarios mean. I guess this is looking at syphilis prevalence. I guess what the top line here is really the no change since 2013 scenario, which was that continual growth in diagnoses. Oh, hang on, sorry, no, that's no change since 2020. Sorry, so that's why you're seeing this plateau. There was a typo there. Otherwise, I guess most other scenarios, which an increase up to 60% coverage, do see a big decline in the syphilis prevalence. And the impact of community-wide testing, where you have a lot of people being tested in a short period of time across all communities, I guess, did have a little bit of additional impact, mainly sort of bringing forward the reductions, but it's not too much difference to just having a really high testing rate. Community-wide testing by itself, without that increase in coverage, does lower the prevalence, but doesn't really bring it down towards the lower levels, towards the pre-outbreak levels. So I think this is my last slide. I'm sorry I'm not keeping track of time, but I guess the conclusions here are that our modelling suggested the enhanced response up to 2020 prevented a worse epidemic of syphilis, which I guess is a good thing. But this response needs to be maintained, ongoing into the future, and you would need additional interventions that lead to an increase in annual testing coverage to reduce syphilis prevalence to pre-outbreak levels. Unless it's substantially increased, you are unlikely, from the model, we're unlikely to see that decrease into pre-outbreak, syphilis outbreak, that is, levels. And I guess, greatest impact is going to be achieved when you have the, increase in coverage reaching a high level in the shortest time possible. As I said, with the community-wide testing in remote locations, this could further reduce the time to eliminate syphilis, I guess, or to get it back to pre-outbreak levels. But, in the feasibility of it needs to be assessed, but if feasible, it should sort of all be done at all locations at the same time. If it is we did look at situations where we sort of roll it out over time through a year, and I guess you get less impact. And I guess it makes sense with population movement and syphilis sort of being moved around the community, and with the regional centre not having the community-wide testing occurring, you sort of get continual spread or reseeding of the outbreak. And I think I already sort of said that, so I may have actually had a double check there. But I guess the bottom line is that to eliminate the syphilis outbreak requires annual population-wide testing in the Aboriginal population to reach a substantial proportion of the population, and that needs to be maintained, I guess, until you get down to the really low prevalence levels. I think that's all I wanted to say today, and I just wanted to acknowledge everyone who was involved in this work, in particular Ben and David, who co-led this work with me in the generation of the reports and the paper and all the work. I think that's it. Thank you.
I've got time. I can literally take one or two questions if anyone has anything burning that they would like to ask Richard. We've got one hand up at the back. I can just ask you to speak nice and clearly, and hopefully Richard will be able to pick up on it.
Well, thank you very much for that presentation. I haven't read you before, but certainly I'm always very impressed with David Regan's skills of analysis. My question is about your actual design. And in sexual health, we have this concept called core transmitters. And so your model actually doesn't talk about core transmitters as being a way to focus in. And so why did you choose that model, and why did you choose not to focus also on core transmitters?
So can I just double check that you're saying core transmitters?
Core, yes. So in sexual health, we recognise that there's often individuals who are more likely than other individuals to...
Yes, yeah. Sort of like a higher risk people to become infected and to transmit the infection to others, I guess. So I guess they're sort of inbuilt in there, but they're not a focus of the testing strategy, I suppose. One, partly, I guess it's around identification within the communities and regional area. And I guess when we were modelling this, the goal was really around interventions that increase testing for everyone, as far as I understood. And this was the aim, is that they really wanted to increase testing generally. I mean, the prevalence is relatively high within the outbreak areas, in the affected areas. And I guess also with pregnant women and other things like that, they're just wanting to get the overall testing level higher in the female population and the male population. So yes, you're right. We didn't really focus on potential interventions into core, I guess, transmitters, as you said. We could have, but I guess that wasn't really, it didn't really come up as a intervention scenario, I suppose.
Thank you, Richard. We're going to move on now, so thank you very much for joining us, Richard. If we can thank Richard for the class.
No worries. And please get in touch if you get any questions or whatnot. I know it's a short time, but yeah, nice to present to everyone. Hope you have a good day.